Blood pressure is measured in millimeters of mercury. Systolic blood pressure is the maximum pressure exerted on arteries when the ventricles contract or eject blood from the heart. Diastolic blood pressure is the minimum amount of pressure exerted on those vessels, and this occurs when the ventricles of the heart relax and fill with blood. Blood pressure reading is written with systolic pressure written on top of the diastolic pressure. For example, 130/76. Keep in mind, this is not a fraction though. The difference between the systolic and diastolic pressure is called the pulse pressure. We teach and emphasize checking blood pressure manually, even though in different clinical settings, you will see automated blood pressure devices being used. Normally, the systolic blood pressure is 10 to 40 millimeters of mercury higher in the leg than in the arm, but the diastolic pressure of arms and legs are similar. Blood pressure is mostly measured using the upper arm. So besides the upper arm, what are other alternative locations for measuring blood pressure? What are a few reasons not to measure blood pressure on the upper arm? I want you guys to read about that. Let's talk about orthostatic blood pressure or hypotension. Orthostatic is a series of blood pressure measurements when the patient is in a lying, sitting, and standing position. Orthostatic hypotension, also known as postural hypotension, this occurs when a normotensive person's blood pressure drops 20 to 30 millimeters of mercury with any position change. They may or may not be symptomatic with this blood pressure drop. To check for orthostatic hypotension, check your patient's blood pressure in supine, sitting, and standing positions. Most orthostatic hypotension happens within 1 minute of position change. For this reason, do not wait for more than 30 seconds between each reading. Leave cuff on for all three measurements. What are the expected ranges of blood pressure noted in your textbook? What factors can affect blood pressure readings? Using wrong technique can affect the blood pressure reading. Let's talk about common errors associated with blood pressure measurement. Errors resulting in false high blood pressure measurements are if patient has legs crossed during measurement, if patient's arm is positioned below the level of the heart, if a cuff is being used that is too narrow for the extremity, or wrapping the cuff too loosely or unevenly, deflating the cuff too slowly, re-inflating the cuff before completely deflating it, failing to wait 1 to 2 minutes before obtaining a repeat measurement. Now we'll talk about errors resulting in false low blood pressure measurement. Positioning the patient's arm above the level of heart, using a cuff that is too wide for them, not inflating the cuff enough, deflating the cuff too rapidly, pressing the diaphragm too firmly on the brachial artery. When I say diaphragm, I'm talking about stethoscope diaphragm there. Let's go over oxygen saturation. This is measured by a pulse oximeter that estimates the oxygen saturation of hemoglobin in the blood. Oxygen saturation levels lower than 90% are considered abnormal. That will require further evaluation. Let's take a look how to check oxygen saturation levels using pulse oximeter that we have in our lab. Here are two different kinds of pulse oximeters. They're used to measure the oxygen saturation level in arterial blood. And here, as you can see, one of them is showing my oxygen saturation level as 97% on room air. The other one was showing 96% on room air. They're pretty close. Be very clear when documenting or verbalizing oxygen saturation levels, specifically if the patient is on room air or supplemental oxygen. Because room air is 21% oxygen. You will see the symbol FiO2, which is fraction of inspired oxygen. That's the percentage of oxygen the patient is breathing in the room. And supplemental oxygen increases oxygen concentration as high as 100%, depending on their device being used.